Hello, everyone. You're welcome to next year's Health Dialogue on Revitalizing Nigeria's Primary Healthcare System. The Primary Healthcare Dialogue is the second event in next year's Universal Health Coverage Series. We started this series a couple of months back. This series would explore different thematic areas relevant to universal health coverage, such as health systems governance, health financing, and several other topics. So today is just one of the events in the series. To guide us through the activities for today is Dr. Uju Onyes. Dr. Uju is a public health physician with over 10 years of clinical and public health experience in sub-Saharan Africa and Europe. She has worked with multiple stakeholders in the areas of health system strengthening and health financing. Today's session promises to be interesting, and without wasting your time, I'll quickly hand over the reins to Dr. Uju, who will be moderating the rest of today's session. So Dr. Uju, over to you. Thank you.
Hello, Chidima. Thank you so much. Hello, everyone. Good morning, good afternoon, wherever you may be. It's a pleasure to see you all here, and thank you again for joining us. So before I start off my session, just this session, just a few housekeeping rules to remind us. If you could please keep your speakers on mute if you're not speaking. Would appreciate if you could also put your phones on silent. And then throughout the duration of this session, there's the Q&A chat box feature where we implore you, if you have any questions, please type the questions into the Q&A feature. And then when we get to that part of the session, we will ask your questions to the panelists. So on that note, please enjoy the conversation, and we look forward to you engaging with us. And to start off this session formally, I'd like to invite Dr. Ibrahim Mustafa, who is the Permanent Secretary of the Primary Healthcare Board, and he's representing the Commissioner of Health for Lagos State, Professor Sam Abayomi. So Dr. Ibrahim, over to you.
Okay, thank you very much, Uju, for that brief introduction. I'd like to welcome everyone to this discourse. Indeed, it's a very apt and timely one that we're discussing revitalizing the Nigerian primary healthcare system. I just like to chip in that some 2-3 months ago, we had a meeting at Abuja discussing virtually what we are discussing now. And I was talking about reimagining the primary healthcare system in Nigeria. It involved stakeholders all over the country, including commissioners and relevant stakeholders and all sorts. And we discussed this at length. This only suggests that the primary healthcare system in Nigeria actually is not in the best state that it should be, if you look at the whole country in general. We in Lagos, I think we're doing much better than many parts of the country. And that is not self-eulogizing ourselves, but I mean, it speaks to itself because a lot can still be done, even in Lagos and in other parts of the country. We all know that the primary health care setting is the closest to the people. Whether we like it or not, as of now, more than 80% of the population, even in Lagos, I mean, more than 90% still access what we will call the primary healthcare setting. And in this, we'll be talking about the primary health centers. We'll be talking about even the traditional thing, we're talking about some private settings offering primary health services. So we need to have the primary health care level developed to a satisfactory one for us to say we are reaching a good number of our people in the country. But unfortunately, this the primary health care setting is bedeviled with all sorts of chief among which will be infrastructure, HRH, and the governance structure itself, including financing, which you earlier talked about. All this, there is none of them that you can say is well developed. And if we begin to look at it, I mean, people will say the first thing, if you have an ailment, is to really know that you have that ailment. And once you know you have that ailment, you have insight then you can begin to address that. So this is like telling us that these are the problems, and this is the start-off point for us to begin to address these issues. They are indeed very germane issues that we have to address and we have to tackle head-on for us to begin to say we're dealing with the health of the people. I must say this is apt. It's coming at the right time. And I will hope that at the end of the discussion today, we'll be able to come to some conclusion that will be useful to the system and better the health of our people. Thank you.
Thank you so much, Dr. Ibrahim. That was a fantastic opening remark that will set us off into this session. So for today's next year's UHC Dialogue series, we'll be focusing, like Chidima said, on the challenges facing Nigeria's primary healthcare system. For today's session, we have three fantastic panelists, experts who are worked at the different levels of the primary healthcare system within Nigeria, and they will be giving us an overview of the challenges that have affected primary healthcare and possible recommendations from their own experiences. We have Professor Chima Onoka, who is the head of operations from the Health Policy Research Group, who's also worked very closely with the National Primary Healthcare Development Agency. We have Dr. Sam Abo, who is a senior health advisor for the Foreign Commonwealth and Development Office in Nigeria, which is like from the donors aspect. And then we also have Dr. Emmanuel Obetu, who is the director for primary healthcare at the Kuchi Area Council Health Authority in Abuja, the Federal Capital Territory. So on that note, I'm going to ask the panelists to introduce themselves. Please take a couple of minutes. I'll start with Professor Chima Onoka. Please tell us about yourself and your background.
Thank you very much, Dr. Ju, and thanks to everyone for being here, for making our time to be here. My name is Chima. I am a public health physician and also a health systems economist. And like she said, I've worked a bit at I've worked at the primary level and then also worked at the tertiary level as a consultant in a hospital, and then taught a bit in the medical schools, teaching things around primary healthcare, and also worked at the policy level, and then have some experience with research. And then I hope to, that we'll have a very good conversation that will lead to something or catalyze interest in the things that we're talking about today. Thank you very much.
Thank you, Professor Chima. Next up, we have Dr. Sam Abu. Over to you, sir.
All right. Thank you again, Uju. It's a great pleasure to be with all of you. Okay, I'm a medical doctor, an epidemiologist. I've been in public health for the past 4 decades. Worked for UNICEF for 24 years and WHO as well. Been all over the world, headed Save the Children abroad and Merlin. And so, and now ending the evening of my career with as a senior health advisor with the British High Commission in Nigeria. So it's a great pleasure to be with you all. Introduce a lot of initiatives in Nigeria, including the house-to-house polio eradication initiative, the IMCI, which is Integrated Management of Childhood Illnesses, also designed and actually created a problem of MPI. So a lot to talk about, a lot to learn, a lot to share, and a lot to remind us of what we need to do to make it right. Over.
Thank you so much, Dr. Sam. And last but not the least, in any way, we have Dr. Emmanuel Obetu. Over to you.
Yeah, hi, Uju. Yes, hi, Chima, and hi, Sam. Nice to see you here. I'm Emmanuel Obetu. I'm a public health physician. I have about 14 years experience in public health. Interestingly, most of my experience is in primary healthcare at the decentralized level. I've also been privileged to have had international experience with the Stop Transmission of Polio program, where I served in Ethiopia for 2 years with CDC, WHO collaboration. And that was also supporting primary healthcare system, specifically immunization. I'm currently the director of primary healthcare, Kuji Area Council, and I also have some implementation research collaboration with the University of Abuja Teaching Hospital in the hypertension treatment in Nigeria implementation research project. And in the course of my primary care experience, of course, I've been exposed to a lot of tax shifting and tax sharing policies and practice. And I'm glad and happy to be part of this panel.
Thank you so much, Dr. Emmanuel. And thank you once again to all three of you for being here. So I'm going to start the panel session by setting the scene for us. So using the Alma Mater Declaration, which we all know are very aware of, are familiar with, which has identified primary health care as key to the attainment of the goal of health for all. How well will you all say, and this question is for all three panelists, how well will you say the primary healthcare system in Nigeria is performing? I'll start with you, Dr. Emmanuel.
Okay, well, I was hoping you would start with Prof. That's fine. So for me, we don't need to reinvent the wheel. The original definition of primary healthcare is packed full of a template that we can always go back to. Unfortunately, we seem to be deviating from it, and probably that's where the problem is. It's essential health. Then we talk about scientifically sound, and you talk about something that is socially acceptable. So when we design primary care interventions and we don't look at this definition, a definition that has, even as far back as 1978, was very futuristic, then we'll see that we probably are just trying to reinvent the way that we shouldn't really reinvent. When you look, because even the concept of universal health coverage that we talk about now, it's just more or less primary health care reimagined, or primary health care redefined, because all the components of universal health care still goes back to the issue of primary health care. When you talk about the issue of accessibility within the original definition of primary health care, it talks about at the cost the community and the government can afford. And it now talks about looking at evolution. So when you talk about the essential healthcare, you also look at evolution such that depending on what the community and the government can afford, you can add on, you can continue to improve probably what we call benefit package now in the context of maybe insurance or basic healthcare services. So for me, primary healthcare, we don't really need to redefine it. We just need to look at it as a framework that will guide us in whatever we're implementing.
Thank you, Dr. Emmanuel. And I think he already called you up. So Professor Chima, over to you.
Okay. Emmanuel, thank you as well for even saying most of it, But really, just to add, it's still the same, when you look at something that happened more than 40 years ago, and then you get back even to the Astana Declaration point, and you're still talking about the same thing. I mean, are drugs available? Are you offering maternal and child care? Are you preventing endemic diseases? Are you treating common ailments? Are you, it's the basic thing. Are you still offering immunization? Is there water and sanitation? That's what we've been talking about since 1978. That's still what we're talking about today. And that tells us that, I don't know whether it's to say that we'll have work to do or that we need to think about ourselves and how we actually do what we're doing and whether we mean business. Yeah, thank you.
Thank you, Professor Chima. So what I'm really hearing from both you and Dr. Emmanuel is that you believe that there's no need to really redefine or reinvent, that it's really about implementing in the right way the current structures that exist and finding how to, do them the right way. That's what I'm getting from both of you. And so, Dr. Sam, over to you. Any inputs on this question?
I want to build on what my other two colleagues, Chima and Ima, have said, but to remind everybody, prior to Alma Ata 1978, Nigeria started the basic healthcare program in 1974. We had a village health worker system. So if you want to, as an epidemiologist, you asked me, well, how is your wife? I said, compared to whom? So I want to look back, like Chima has reiterated, 40 years or 44 years of doing this business. Sorry, I must say Nigeria's primary healthcare is in ICU. it's getting resuscitated, but the patient is not responding. And then I hope in the course of this discussion, we'll be able to clearly say why and what needs to be done. So I'm being frank, it is non-functional, it is not operational. So we need to go back to basic, resuscitate this baby and then keep it alive and then scale up. Because listen, a lot of things have been learned from Nigeria, but Nigeria is like, we're going back to the baby steps of trying to learn from other countries. We taught other countries using our village health worker system, basic healthcare approach, and all that. The 10 components, if you look at it, of primary healthcare, you can just, none is even up to 80%. So we're not there. We're just in ICU. And I think hopefully we won't just do blah, blah, or talk. We need to walk the talk. And I think, I'm sorry, but I'll give my own perspective. I've been in this business for 4 decades. I'm not happy. I'm very disappointed, but we can make a difference. But I'm an optimist anyway.
Thank you so much, everyone, for that. And I really do hope that we could use this conversation to really identify what these challenges are and come up, using your experiences, come up with, really sound recommendations that we can then push up to the policymakers on how we can resuscitate the primary healthcare system in Nigeria. So on that note, Professor Chima, let's really talk about specifically primary healthcare in Nigeria. Like, what role has it played so far in helping Nigeria attain its policy goal of universal health coverage? What are the challenges? What is going right? What's going wrong specifically within the Nigerian context?
Okay, thank you. And thank you, Dr. Sam, for hitting that point as well. And, I'll build on it. Now, for every country, like we know, everybody is aspiring to achieve universal health coverage, and you need to start from somewhere. Even if you don't want to, you have to start from somewhere because resources are limited. And if they are limited, then we have to find the part of the entire healthcare delivery system where you can get the maximum benefits, by investing even the least, where your input, even the least input, you can get the best, and that gives you a foundation. And that's really what makes primary healthcare what it is, that's the best place to start. And both from a moral angle, an equity angle, and also an investment angle, it's just the best place to start. So the seriousness of a country when it says we want to achieve universal health coverage can be read by examining what is going on with the primary healthcare level, the primary healthcare system, beginning from the issues of, look, have we got it defined clearly? Is it a system? Is it a package of service? Is it a package of facilities? Is it, something we talk about that people, is it a position? What is it that we call it in Nigeria? It may sound like we know it, that Nigeria is we're running primary healthcare, but just go out there and ask even people working on different platforms. Some see primary healthcare as facilities. Some see it as primary healthcare service, basically thinking about basic service, basic care that is different from, things around, public health protection. Especially for the things that have to do with vaccines and immunization and protecting from real pandemics and all of that. So, but that definition is affecting us. But that's where it will start if we are thinking that we want something that we want to use as a foundation to work towards universal health coverage. Will I add dialysis care? It's important because of the need that some people have. Will I add some of the other services when primary health care is not in a way that people even have access to that care? Let it be that they have access, but they are not comfortable. They have more money to spend, and so they choose something else. But this, something that is qualitative enough, that has the right quality rather, is available and accessible. And I think if you examine our approach and where we are going from here, granted that we've said a lot of things about universal health coverage and we want to get there, but the lens is the lens that we answered in the first question. What is the primary healthcare situation like? If it is not there, then we've not started making progress, really.
Thank you so much, Professor Chima. I'm really hearing that we need to not only define what really primary healthcare is within the context of Nigeria, we also need to find ways to provide services that reflect the needs of the population adequately and of higher quality to be able to meet the needs, the healthcare needs of that population. Is that what I'm hearing from you? Thank you. Thank you so much for that. I really do agree with the defining that system. And yes, that's a very key point. Thank you. I'll come to you, Dr. Emmanuel. Let me come at you from the service delivery part of the primary healthcare facilities. Can you tell us some of the challenges you're facing, especially at the facility level, in relation to primary healthcare?
Well, talking about challenges, I think to a very large extent, may seem that all we are contending with now is just challenges, because the primary healthcare approach to organizing our health system in Nigeria has never really worked as optimally. So that means the bottom line is that there are numerous challenges. But I will just prioritize here, because there are key things that I believe, if put in place, will go a long way to achieving our set goals. But overall, for me, the biggest challenge we have in our primary healthcare system right now is human resource for health. Human resource for health in terms of number, in terms of mix, in terms of distribution, and in terms of maybe quality. And probably there are other challenges that are there. In terms, there's infrastructure challenge. There's also the challenge of access for the communities, the catchment communities, and then probably have financing challenges. But of this, I'm sure if we have the human resource needs in terms of looking at the minimum service package, we would have solved probably, if I hazard a guess, more than 50% of our primary healthcare challenges. So how do we go about then? What are the possible ways of solving some of these challenges? We have some low-hanging fruits, but there are some that you need to deliberately recruit. There must be deliberate recruitment. Then there must be equitable distribution of the personnel. We also need to take advantage of tax shifting and tax sharing policies that we have, possibly expand the scope, not just focusing on maternal and child health, sexual and reproductive health, but going into other needs like non-communicable disease. We need to take advantage of existing pool of maybe non-technical staff that can be converted to areas that they can function. Maybe probably in the course of the discussion, we could highlight more of this, but I'll probably just hang it here.
Thank you, Dr. Emmanuel. I see an interesting comment on the chat, and I wanted to it's in relation to this. Olufunke says that she would like to draw attention to a very important topic, which is the urgent need for implementation of a policy on access to rehabilitation services by patients with disabling conditions or established disabilities. I think this is in your area, Dr. Emmanuel. What do you think about her comment? And is this something is there any structure around this at all at the primary healthcare level, facility level?
Everything is possible at the primary healthcare level, because the primary healthcare system is centered around early detection, early diagnosis, and prevention. And rehabilitation, by extension, is a form of prevention. And so at the end of the day, when we look at the key challenges, human resources, it will need, either you need to increase the number and the mix of human resource, You also need to increase the skill, the expertise of the personnel so that they can deal with things that have to do with rehabilitation. And this rehabilitation care, because primary health care needs to be linked to other levels of care, because a lot of the reconstruction or rehabilitative interventions that will be done will not necessarily be done at the primary health care or the primary care that is provided through the primary health care system. But in terms of continuum of care, you need the primary health care system to be able to serve persons who are being cared for their rehabilitative needs. And they won't need to be going to the general hospital or the teaching hospital every time if the primary health care facilities that provide primary care have the capability within the primary health care system to provide these rehabilitative services.
Thank you so much, Dr. Emmanuel. I'm really hearing that a lot of the challenges that you face at the facility level are related to human resources for health, capabilities, numbers, and also, and also really around infrastructure. Those are some of the key points that I picked up from your response. So my next question is for Dr. Sam. So my question is really around the actors related to primary health care. Which actors do you feel are most important in strengthening primary health care in Nigeria? And how can they be leveraged on to improve the performance of the primary healthcare system to be able to provide quality health services?
Well, let's start. I want to always start with the people. When we talk about society, communities, nations, we're talking with people. So the first thing is, do people know their rights? Are they demanding their rights? So we need to look at the people, and are they, applying the basic health education we offer in terms of family and community practice? That's first and foremost. The second part is the duty bearers, and that is other stakeholders who say they want to act on behalf of the rights holders, which are the people. What are the CSOs, faith-based organizations, NGOs doing? And are they advocating, are they championing the rights and making sure that those disparities, those vulnerabilities we see are mitigated? And everybody always looks at the government, but I want to put the government as last. You look at the private sector. How are we engaging the private sector to be, to reach the unreached, to fill in the gaps where government does not fill, the public service does not fill? So the fourth person is government. Okay, if you look at government, what is government focusing on? If you analyze the national health account in the last 8 years, the focus has been mainly on curative. Prevention has had very little investment. So what is the return on investment? Primary healthcare is not only a low-hanging fruit. And I go back to what Chima was trying to emphasize. Primary healthcare universally has a definition, but each country is allowed to adapt to that, but against the 6 principles. Whether it is one, if you look at it clearly, are we talking about, is it an appropriate approach? 2, is it an acceptable approach? Thirdly, is it accessible? And fourthly, is it available? And fifthly, is it affordable? And is it at the level of people's development? If you look at Nigeria, there are typologies of countries in Nigeria. State Borno is not the same as Lagos. Same is not the same as Ogun or Kano. So we have a challenge with that. So in addressing that, the governments either have to make it a mandate or manifesto, or take the responsibility, because they provide the enabling environment, the policy environment, and therefore an investment that is required to push for primary health care. So that's the thing. The last bit is the private sector. How do we get, the donors. The donors are off budget. They come and do their business and get out of this place. How are they aligned? How are they harmonizing with government plans? And how is this their catalytic investment, making some difference, not substituting government, not coming to run a vertical health system support program. No, malaria, immunization. Is either we have an integrated package that is aligned with government vision and people's demand. I think we're not going to get anywhere. We're just going to be, putting bandage over the wound. And I'm sorry to say, that's what has been happening in the last 40 years. So we need to change. Over.
Thank you so much, Professor Sam, Dr. Sam. Very passionately delivered and very well heard. Thank you. And really, that brings us to like you talked about the financial aspect, the investment, and the health financing aspects of primary healthcare. So I have a question for Professor Chima. Like, we're all aware that there's been a lot of investment in primary healthcare as a whole in Nigeria. And this has been done through both domestic and donor resources, external resources. But despite all of this, the healthcare improvements have not been commensurate with the investment, particularly in the PhD level, for some of the reasons Dr. Sam mentioned in his last response. How do you think Nigeria can refocus its efforts to ensure not just efficient use of the resources that it currently has? So we're looking at it in different ways. Like when you talk about health financing, you're looking at the amount of resources available. So looking at that, and then looking at how also to use the resources you currently have, not just expanding, beyond expanding the fiscal space, the current fiscal space, how to use it efficiently. And then also how to make sure that you're using it to purchase the needs, purchase the healthcare services that are quality healthcare services that will meet the needs of the people. So what do you think, just talking about how do you think Nigeria can refocus its efforts to ensure that it finds a way to do this? It's a very heavily loaded question, so you can I'm aware.
I think it's very loaded, so I'll say a few things and then colleagues can also add when they are speaking. I think it begins from that part of telling ourselves the truth, and without which we can't really move forward. There are things that I would say have happened, even over the past few years. For instance, I know that we are at an existential point. We are threatened existential in terms of immunization. So the last few years, like from the NPSCDA, they focused on immunization, getting that sorted out, and then now building on that for other things. It was an existential issue with Gavi especially. Now, for the country generally and speaking, I think we need to work from that perspective of truth. We tie ourselves to things that don't help us. And, I stand to be corrected. But you see, when I grew up in a family that was doing primary health care, my late mom was a primary health care coordinator. And I saw primary health care work when I was, a child. I saw it up to the time I entered the university. I saw it work with the little resources that was available. She was not a doctor, she was a nurse, but extremely experienced. Now, we have things that are ideals. Maybe our ideals are keeping us from working based on what is practicable, what is realistic in our setting to drive things forward. An example, I believe that you can pay for people to be heads, for instance, and I know that this may sound controversial. You need medical officers of health, but you can't have them because we have limited resources. You can't pay doctors to be in every LG. What is the option that will work in our country? Let's figure it out and focus on it. Around Sam Kuti's time, there was a lot around community health extension workers, and it was clearly defined, this is what you should do. We had the examples that these can do a lot of work for us, but are we investing sufficiently in that system to provide and fill up the gaps and give them something to look forward to even when they reach the peak of their career? And some of them that are very good to build on that. Is it something that we do, or the ideal which we cannot attain, we write it on paper and then we can't engage with what is realistic? We are having more human resource crisis. What's going to be our solution to it? Which I think is, out of all the health systems blocks, the most important is HRH. If you don't get that sorted, nothing else can work. Nothing else will survive. There's nothing, if you don't have a midwife in a primary health setting, nothing else will survive in that place. It's not going to work, at least to a reasonable extent. And then, so the third thing, such systems, we actually need to plan. From things I hear, even the US has a shortage they are declaring. They're going to need nearly 500,000 nurses in the next 3 to 4, 5 years. A lot of them are going to come from Nigeria. there has to be something we are doing now to solve that problem. Otherwise, we are not planning. And then, the one final point I want to make is the investments that we are making. Quite often, we don't make them long enough. We don't settle on them long enough. So if we have produced a document and then we start doing something, we spend a bit, we say we have done that, even if we haven't really spent time to get to the point where it should produce the results. So if you ask us, we say, oh, we've tried this one, we've tried that one, we've tried that one, we didn't try them long enough and we never evaluated them. There are experiences that many, especially even partners, and then states have tried in the places where they are. Those things, Nigeria is like 37 countries, that there are enough, the experiences to pick from one place and apply, package it and apply in other places. And, they are the kind of things that, I just want to speak about now. Thank you.
Thank you so much, Professor Chima. Dr. Sam, please go ahead. I see your hand.
Really very much, because I'm like I said, I'm very disappointed, but I think there is hope. First, if you look at Nigeria's health policy, it states that primary healthcare is the cornerstone strategy to achieving health for all. Now, having looked at it, and I want to follow up to say we in Nigeria have enough money. There's enough money to do whatever we want to do and achieve whatever level of results we want to see in the next decade. However, inefficiency and ineffective use of the resources, that is manpower, money, and material, has been our bane. If I can tell you, I went to the national store. You find things are in the cold store. They shouldn't be in the cold store. They should be in the service delivery point. If you go to human resource, is this a problem? No. If you look at the analysis of data, the community-owned resource persons, these are the community health influencers and providers. They are not there. We have a ratio in my time, we used to say a ratio of 1 to 2,000 population. We need to build that up. The community health extension workers, they choose junior choose and senior choose. These are the elements that where government investment should go. They are inadequate. It's not in the nurses and doctors. If those chips, community resource persons, can assess, classify, and identify danger signs, what we're looking at 80% or 85% of the problems will have been solved. Then they can refer where critical management for those who have danger signs, complications, which are 15% of the population, of those targeted population. It will be something to deal with at the secondary or referral point. Having said that, the other thing is that we've looked at management. We think it's health management. No, political management. If we look at when we introduced Bamako Initiative in those 80s, the capitation was done by the stupid local government chairman. I'm sorry to use that word, to be rude. He was just there, took the money and went and built health centers where there was nobody, rather than reinvesting the money in the commodities and in the payment or remuneration of the health workers. So I basically said, no, if you go, sorry to say, Chima, there are evaluations, but they are not public, because I can tell you without even blinking, the poor performing states in Nigeria, poor performing local governments, without even, they have been consistent for the past 40 years. And what have we done as donors? We keep investing our time and energy in those very poor performing things. And I said, no, can we change our mindset? Look at this, equity is not going to get us anywhere. Somebody who is willing and performing, I can see where Lagos State has come from. I can see where Oshun has come from. I can see where Nasarawa has come from. But when you go to areas like Kano and Sokoto and Zafara, and then you now start telling me, oh, we need to invest. Sorry, they have to take responsibility. And the last point I want to make is that if we don't address the demographic transition, we are piling up people who we cannot provide services for. Chima had talked about social determinants, water, education. No, these are the people who are spilling over, and we'll continue having the same problem because we are pretending, no, we don't want child spacing. Oh no, family planning shouldn't be on the agenda. In the Rason Kuti time, it was advocated that at least 4 children per family, so that you can manage, educate, let them survive, grow, and develop. What are we doing? We are pretending the ostrich, put the head in the sand. No, we want infrastructure. I disagree with the permanent secretary. We don't need infrastructure. We need community-owned resource persons. Let every community. When we did the acceleration of immunization in Ekiti, it was not infrastructure, it was people. When we eradicated smallpox, the people. When we eradicated polio, people. Please, let's invest in the people and educate our people. Whether it's education, whether it is primary care workers, let us recognize that they are not volunteers and they should be paid. And I don't agree with all this voluntary. Nobody, I don't volunteer. I get paid and I get well paid. So I must deliver. So I'm sorry. Let us move from the talk to the truth and get it done. We can do it. I'm telling you, I have walked around Africa. I have seen people, South Sudan, Sudan. I worked there for 5 years. Today they are top. Their coverage, effective coverage is high and it's sustained. And it started with simple things. Let us agree, we have a package, basic healthcare package, fine. Let us see and implement it before scaling it up. Because I'm sorry, I'm not being emotional, but I'm very disappointed that we're still talking about the same thing that we talked about when I was in medical school. So I'm sorry, there's something wrong, over.
Thank you so much, Dr. Abo. I completely agree with you, especially related to the people aspect and especially the community health workers. Having done a lot of work across Sub-Saharan Africa in a couple of countries on community health workers and the fact that they should be remunerated and the impact of remuneration and recognition on their work and the kind of the improvement on the indicators once you remunerate community health workers and basically make your primary healthcare structures focused on people as opposed to infrastructure. And I really completely agree with what you've said, Dr. Chima. I do agree. So I'm going to add, sorry, Dr. Sam, I beg your pardon, not Dr. Chima. So I'm going to move to Dr. Emmanuel. Do you have anything to add to this current topic?
Well, so what has been talked about touches a lot on governance and health financing. So I will share a few thoughts. Let me paint a quick scenario. You have community A and B separated by a stream, and that stream is very difficult to pass during the rainy season. Community A has a primary healthcare center. Community B doesn't have one. But the combined population of community A and B is probably around 5,000. So, and community A primary center has enough staff that can serve both community A and B. And the population is okay, just about 5,000. But community B cannot access the primary healthcare facilities in community A, particularly in the rainy season. And community B thinks they need a health center. They advocate to get a health center of their own. And you get donors piling up, coming around to see how they can support community B to establish a health center. These donors cross the river. They get a speedboat and they cross the river and go to the other side and build a primary healthcare center. Probably that will cost maybe 50 million or whatever with equipment. And that health center would need staffing, equipment that will be sustained for life. Whereas all probably they needed was a bridge. So we need to focus on where our finances are going. We need to understand that in order to be able to solve some of the health problems, we don't necessarily need their interventions in the health. There are interventions, for example, that bridge alone will just solve that problem for access for community B to the primary healthcare center in community A. So I probably will rest this thought here, because this scenario, which I just thought of, is something that touches on a lot of the aspects we are discussing here. You see donors focusing on their own priorities without considering or looking at wants versus needs. The community wants a primary health care, but is that their need? So donors must clarify what are the actual needs, discuss, engage with the community, and let them know you want this, but this may not be what you need. Unfortunately, donors or partners or sometimes they have their own focus. They just want to say they are built a health center, whereas that may not be what is needed there. Two, communities may also begin to trust some actors. Of course, I know there may be actors or technical leads who are not sincere, but I believe a lot of us are sincere. They must trust us to give them the best of advice, to let them know that you don't need a health center. What you need here is a health post. You don't need to have a doctor in this primary health post. There's a doctor just less than 5 kilometers there in the next health. So communities should begin to also trust us, and we should provide ethical advice to communities without thinking about personal benefits.
Thank you so much, Dr. Emmanuel. Dr. Sam, please go ahead.
I just want to add the fact that, listen, in my work, other life with WHO, we had 8 what we call then pilot LGAs or learning LGAs. And we introduced a concept of how we could have a medical officer from the NYC, a statistician, and then a social mobilizer. And that was how we strengthened the district system, health system at that time. And this was what was adopted in 1991 by Nigeria after the high-level mission. And they created the National Primary Healthcare Development Agency. So let me say this for fact that guidelines are there, strategies are there, but it is the how-to. Right now, I find people don't even know the history. They start telling me stories now, and I'm telling them, listen, we had a system, and that was why Primary Healthcare Development Agency came about. But now Primary Healthcare Development Agency is an implementing agency. It is not a technical agency, because how much can it offer to states and to local government? 700 for local government, it won't work. You have to devolve, 1. 2, you have to deconcentrate, meaning that you must have the right skills and right kind of persons in adequate number to deliver the service. So you, Dr. Ima, you're talking about the bottlenecks. The bottlenecks we know, but if you don't devolve, if the states control the resources for local government, it won't work. When Babangida and Co were there, 4% was going for education, 4% was going for health. But the only problem we had at that point, it was the political management where there were decapitation of funds and, but nobody was kind of disciplined. Right now with democracy, it's difficult to ask, even within Lagos, every local government doing the same thing, because everybody has their own priority. Then you talk about the states. Every state would not want to conform even to the national strategy. So democracy in itself is a challenge in how we agree and work. And that's why I believe that a people-centered approach, yes, will determine their needs and they work within their available resources. Rwanda is working why? Mali is working why? Because you have a benevolent autocratic leadership. Nobody, and it's community-driven. So I'm sorry, we have to play this bottom up, and I'm singing that song, and I'll sing it till I get out of this world. But we need to change. Over.
Thank you so much, Dr. Sam. That really brings us perfectly to the next question, which I really want us to discuss around the structures, the governance structures for primary healthcare in Nigeria. So right now, like primary healthcare is largely, like you said, the responsibility of the local government with support from the different tiers of government, and then also the National Primary Healthcare Development Agency, like Dr. Sam said, that was originally designed to provide technical oversight, but now is more of an implementer. Let's talk about this. What current structures, can maybe some, Professor Chima, if you could just tell us a bit about the current structures that exist, and then with Dr. Emmanuel and Dr. Sam, you can now tell us about the challenges that you faced with the current structure, and what recommendations, any recommendations on what it should be, what is the ideal for the governance structure for primary healthcare in Nigeria. So first off, to Professor Chima.
Okay, thank you very much. Current structure, of course, we say that primary healthcare is first the responsibility of local government, and then others are meant to support or act on other layers above. But if you are going to, then you need to be sure that the tasks are clear. You need to be sure the authority to do what should be done happens there on ground. You need to be sure that your resources are aligned in that direction and they have power over resources. to manage it. And then the accountability processes also need to be in place, and it needs to be clear. Look at the person that holds this person accountable. And if there's a breach in accountability because of misuse of power at any level, which is corruption itself, then this is a mechanism that we're going to use to engage the society to tell the story, and then the society participates in holding those people who have been given trust accountable. Without this, the local government cannot do that work, and the local government ends up getting blamed. What I talked about 30, 20 years ago, the local government was in charge, really in charge, and they were doing things. I saw it work. I saw people have things that they needed to work. I saw it happen. And so even if nothing else, I won't get confused because of all the new developments that are going on. No, I saw it happen, and it happened at that low level, at the local government area. I saw it happen. And so that vision still fuels me personally. But the local governments can't function like that, because there are many things in the first place that they should do. Because somebody has to manage money, somebody at a higher level now takes this responsibility and wants to do it. And that's the picture that we have. But the person at the higher level, whether it's state or national, the focus should first be, the focus of the work should be that I am here to hold somebody else accountable. Not that I am here to be the one to do. I'm here to hold somebody accountable, somebody else. So my job description is different. My assignment is different. And if my assignment is different, it means that I am willing to allow resources to flow down there. And the resources that I need are the ones that will help me to make sure that I hold them accountable. That's the resource I should focus on. Not that the resource comes to me. Now, I think that, that's one of the major things, because of this, who holds the money, who manages what, who does what, it destroys the local government. Then the local government people get blamed. Then the people who should do what they should do become both implementers and those that are also going to hold others account, and it doesn't work. Once you're implementing and you are supposed to hold somebody else accountable, nothing will happen. Nothing will happen. And then, everything gets covered up. So I think that's where it's this structure, but, except we tell ourselves the truth about what is it that we want to do when money shows on ground. What is it that is our decision? What will be our behavior? What incentives do they create for the people playing at the different levels? Are we willing to handle that? If we're not, primary healthcare will remain what it is, even today. Thank you.
Yeah, I guess you want to follow up.
Yes, I'm back. I'm back.
So,
thank you so much.
So I guess you want me to follow up on this.
Yes, definitely. York, I'm coming to you next. And Dr. Sam, I see your hand raised, because I would like to hear from the Dr. Emmanuel, based off of what Professor Chima said, then I'll come to you, Dr. Sam. But I just wanted to say some things on the chat. Thank you so much. I see the fantastic, very vibrant discussions going on in the chat boxes, and I see a couple of participants have raised their hands. Just to let you know, we have not forgotten about you. We'll be coming to the Q&A session shortly, and definitely we'll give you chances to ask your questions. And anybody who would like to be unmuted, please just raise your hand and we'll unmute you for your comments or questions. So I'm back to you, Dr. Emmanuel. Please go ahead.
Yes, so Prof has actually hit the nail. It's about who controls the resources, wanting to take charge of everything. Putting it in proper context, I don't need to be specific here, but you find people from at the national level coming to the local government to want to do something themselves that they should support us to do and ensure we have done it. I mean, the roles need to be properly defined, clarified, and followed through. If you are supervising or providing oversight, stick to it. At that level of the primary healthcare, it's implementation. And support, if there are gaps in implementation, don't take over those gaps. Fill those gaps, support them to fill those gaps, and watch them do it. You don't have people coming from the federal level to come and distribute nets when they don't even know the communities where these nets should go to, don't know the households. Find people coming from the national level to come and do HIV testing and counseling when you don't know this. So it can be disheartening. But of course, Professor Chima captured it very well. It's about resources. Everybody, so that's why I said earlier that we must be ethical in our approach. And of course, there are no sanctions when people usurp the roles of others. So how are these sanctions going to be implemented? Because I cannot, that makes it difficult for me to sanction somebody that's supposed to be supervising me. But there should be mechanisms whereby when somebody usurps the role of another, the person should face some level of sanction. So these are very, very, very challenging situations that sometimes we wonder how we can navigate and solve some of these problems.
Thank you so much, Dr. Emmanuel. I really do see how that can be really challenging when there's no formal structure and when the oversight body then becomes the implementing body. When this happens, who is providing oversight? Who's supervising who? The implementer cannot supervise themselves. So thank you so much, Professor Chima and Dr. Emmanuel. Next, we have over to you, Dr. Sam. Please go ahead.
Again, thanks, Uju. Just to state it clearly, the primary healthcare documents are there. The ward guidelines are there. How many facilities should be and how many community-owned resource persons should work to support whether the 6 facilities and so forth. Having said that, clearly, the roles and responsibilities, just like people are not playing, within their, if you're doing a relay, if you overstep your bound, there's going to be, you'll be disqualified. And that's a problem from the federal to state. Federal doesn't trust state don't trust local government. So local government is orphaned and nobody's willing to let them learn and grow. Let them make their mistakes. Get the best people, attract them down to the local government. Things will start to change. Having said that, the state primary healthcare development, whatever agency, they are working parallel to the many state ministries of health. There must be a coordination mechanism that brings everybody together on one table so they can deliver as one. If not, it's just going to be just waste of resources. The third thing is that the federal level must relegate itself to occasional supervision or monitoring of states and be able to share learning and also hold those states to account. And that's one of the things that we're saying. So if we don't address the leadership roles and responsibilities, the learning and accountability will just disappear. It will be conflict of interest. You are the judge and jury. Oh, I'm doing very well. My scorecard with fake data. You are doing so well, and yet you have outbreak. So I said, what the hell is going on here? Because if you have an effective coverage, you will have an outbreak. But you see, if you look at the map of Nigeria, and I'll share, unfortunately, I didn't know, I would have prepared something. Because if you look at the Northwest, North Central, and Northeast, this is where the problems are. Whether it is demographic transition, whether it is low coverage, whether it is hesitancy, whether it is poor care-seeking behavior, they all fall into that. But if you look at where money, I give you a case in point. Jigawa invested more than 16% of its budget on health. But do you know what they built it on? Some cancer center. Excuse me, what's the prevalence of cancer in Jigawa? Does it make sense? No, because the problem is misplaced priorities. Where there's money, it is misplaced. Where there's money, it's misused. Where there's money, is stolen. And everybody say, I call it harmful man-made practice. You call it corruption, but for me, people should be jailed. Anyway, over.
Thank you once again, Dr. Sam, and thank you, Dr. Emmanuel and Professor Chima, for this very, very, very exciting session. This has been very engaging, so many interesting points made. I really wish we could go on, and even from the panelists in the chat boxes, very interesting and engaging conversations going on. So before we move into the Q&A session, and I'm sure we'll have more chances to discuss things based off of the questions we have, we've said a lot over the past hour, really said a lot about what the challenges are, what the current structures are, some very key recommendations from all three of you. I just want us to take a few minutes to just summarize some of this. So just give us a summary from each of you, just a summary of what, based off of the challenges that we've highlighted, one or two, or as many as you want, suggestions on 1, 2, 3, 4 things, in your opinion, Nigeria can do. So I wouldn't say to revitalize, what word could we use now? Not just to revitalize, but to improve on the existing primary healthcare system in Nigeria. So I'll start with you, Professor Chima.
Okay, thank you. Number one, that role definition in practice, in truth, role definition in truth is critical. And where you've assigned roles, focus on your own and don't leave your own and do other people's own. Your own will be undone, will be left undone. Number two for me is the human resources. Health workers from bottom to top is so critical. It's an emergency. Whatever we are going to do that we need to do today, whether it has to do with increasing the production, revising curricula, and I say human resources because I see people graduate, and the next 5 years after graduation and they get employed, they are attending capacity building workshops. We are wasting money on most of them. What people are fresh graduates, new people that are coming out of the health institutions are learning as part of capacity building after should be pulled together and handed over to those who are teaching them in the universities and in the schools for curriculum revision. Then we reduce the wastage on capacity building after training. New graduates starts capacity going for all those things. So, and then now think critically about the ones that we have available. And I'll say especially, thankfully, there's been this organizing those working at the community level through the CHIPS program. Then really do something about the CHUs and those community health extension workers. They are part of what we need so much for this country because there are many things that we can't guarantee above that level. We have people, but we need to really practicalize the tax shifting thing that we're talking about. And then, of course, the financing is related to being efficient. Like we said, if those in the local government don't trust very much and states don't trust, even if you send more money even through like the Basic Healthcare Provision Fund and the others, because people may feel that they're not going to even have the power to do something with the funds, other people are going to manage it, they're not going to be very cooperative. They'll wait for you. So we need to think about it, and it's connected to the issues of rules. Thank you very much.
Thank you so much, Professor Chima. Next up, we have Dr. Emmanuel. Please go ahead.
Yeah, so I have a few recommendations. One is specific for human resource for health. Beyond recruitment and redistribution in terms of number and mix, we need to have a deliberate retention policy. A retention policy that has a human face. A retention policy that has the components of motivation, reward, and sanctions. Such that if you are recruiting, Professor Chuma mentioned it a little, if you have a CHU who is having a bar and he gets to that bar, he becomes less motivated. But if you tell this CHU, if you work in so and so place for 6 years, 5 years, we are going to sponsor you to go for a BSc program and possibly for a master's program, or you give that CHU a house with or maybe a doctor who is going to work in the primary healthcare, who agrees to work, say, okay, if you work for 4 or 5 years, you'll be allowed to go and do residency. These are motivation. So the person is willing to go the whole to sacrifice, and it keeps rolling in and rolling out. People will come and replace. That is motivation. And there will be sanctions such that if you renege on providing the care you have agreed to provide, or if you are trained and you don't come back, you will refund the cost of your training. So these are deliberate policies that can advance our human resource for health retention. Then in terms of accountability, I think CSOs need to be more involved. They need to be more deliberate with their roles in driving accountability, particularly CSOs at the decentralized level, not necessarily just national level. We need active CSOs that will come at accountability for what is being done at that decentralized level. Then for the tax shifting and tax sharing policy, I've had this challenge. Why do we have so many persons who are well trained, BSc biochemistry, BSc microbiology, that can function in so many roles? A lot of them are already in service, but they find it hard to fit into the defined cadres. So I feel these are low-hanging fruits. We can deploy them to different areas by providing some form of training for them that will convert them quickly to other things that we need. Some of them can become surveillance officers, some of them can become data managers, some of them can become nutrition officers, some can even fit in the role of laboratory technician. If the Medical Laboratory Science Council will agree to accept some of them and train them to fit into the roles that they have defined. These are not necessarily going to be everlasting interventions, but they are interventions that can fill in the gap and save lives, which is the primary reason why we are having this discussion. And probably lastly, we can look at the issue of private sector. Private sector engagement. Dr. Sam mentioned it in passing too. Private sector, we can talk about contracting catchments to private sector to take charge, or taking over primary healthcare facilities that are not functioning, to take charge and maybe pay them on performance basis. So these are options that we need to explore and be more deliberate about. And although I said lastly, and very lastly, we should not forget the role of technology. We are in the technology age. We must begin to deploy technology to help us fill in the gap. Telehealth, e-health, m-health solutions can help us to bridge some of the challenges we are having in advancing the cause of primary healthcare services. Thank you.
Thank you so much for that fantastic summary, Dr. Emmanuel. Thank you. Next, we have Dr. Sam, over to you.
All right, I would like to just share my thoughts. You don't laugh. Why are you laughing? First, the first and foremost thing that we need to do, I accept and I submit to what my colleagues have said, but the first thing is managing politics. We cannot, I keep telling people, you cannot have fantastic universities if you don't have primary schools, quality primary schools. So what are you talking about? So let's go back to the politicians and tell them, health is a right. We don't want to leave anyone behind. They come to politics, they come and they delegate, let us have a health delegate session where we get investment in the health sector so that it delivers for the people. That's number one. And this is again at the backdrop of health tourism. If you know how much money Nigeria is losing into health tourism to India, Egypt, and UK, and America, it doesn't make sense. It shows that there's enough money in country and we can reduce out-of-pocket expenditure. So we need to make sure that we can trust these leaders, they have integrity to allow the technical people to do their work. The second part is what my colleagues have alluded to, the systems. There are two components of the system. First, we need to rebuild the primary healthcare system. Less than 10% of the 30,000 primary healthcare facilities are functional, but I'm not even interested in the infrastructure in those ones. I'm interested in the community-owned resource persons, the human resource that should be the first point of contact between that family and the health worker. That's where we should invest our money and we'll get value for money and return on investment. And I think I don't want to go into all the bottlenecks analysis that is required, whether it's a supply or the demand or the enabling environment that Dr. Emmanuel was highlighting. The third for me is the people. Do the people demand their rights? Do the people, I think you have something, what is this, something for voting. They must demand for this, I don't know what you call it, POS or PQP, I don't know what, or something, P something. So let them hold their, because there are managerial processes. These managerial processes at the ward level, at the local government level should hold those leaders to account so that they deliver on their mandate. And I keep saying, the CSOs say, oh, we're not involved. You become the champions. The faith-based organizations will not substitute and they only complement government. So the CSOs should be the advocates, champions, and duty bearers demanded that, listen, we don't have enough budget, but we know this money is, and we should share good practices. Local governments are doing well. Let us share that, I call it, whether you want to call it assess and shame or praise and shame, whatever. With this, we already have enough tools, scorecards, blah, blah. Can we walk the talk? All of us are vulnerable. COVID has shown everybody, even if you are the most, I don't know, super governor or whoever, you can die of it. So, but if your system is not there, people are not there, resources in terms of commodities are not there. Sorry, it is just a sad tragedy. But let us learn from China, India, Pakistan, Rwanda, Mali, Niger. They've done well, but it's a people-driven approach. So we need, my key thing is, how do we make it a manifesto, a mandate for the politicians? Because health is a right, and everyone should be healthy. If you're not healthy, you can't be productive. You can't be productive, you can't make progress. So I rest my case. Thank you very much for giving me the opportunity to join this discussion. Hope to see you soon.
Thank you, Dr. Sam. Thank you, Dr. Sam, Dr. Emmanuel, Professor Chima, for that fantastic session. Very, very insightful comments from all of you. Very engaging session. We're going to move into the Q&A session next, but I've been taking a look at the chat box and I've seen some very, very interesting comments and dialogue going on there. And I think it's only right to give a couple of people 2 minutes or a minute to just give us your thoughts on any comments you want to add to this, any recommendations from your end, any challenges you feel were not highlighted during today's session. So please use the raise hand feature and we'll just give you about 2 minutes, 1 to 2 minutes to just briefly say something in relation to this. So I think the first person that raised his hand earlier was Abubakar Ibrahim. So I'm going to just unmute you quickly. Please go ahead and unmute yourself. And
hello.
Yeah. Hello.
Hi. It's a great forum. I actually came in late, but I did see quite a lot of interesting inputs that were raised. But I need to ask a certain question with regards to the healthcare in Nigeria. What are the policies in place in Nigeria regarding healthcare? Because I think I asked that question initially. There's certain sanctions that should be provided to actually help the human resource and the resource material. And like what Dr. Sam said, the politicians should be held accountable. So the structure, the human resource, the material resource and everything, what are the sanctions in place when people mismanage certain policies and assets and stuff like that? What are the things in place? Because I've been to a lot of primary healthcare centers in Nigeria, and I noticed they're all abandoned. Majority of them are abandoned. So what are the sanctions? Who were the people that were given this projects to handle? What happened to them? Why are they not sanctioned? Because in international, in the diaspora where I am right now internationally, if you're a doctor, you can have your own private practice and work in a government entity. It's not allowed. So we have misplaced priorities here, I think so. In the terms of healthcare, there's a lot of misplaced priorities. That's just all I'm going to say.
Thank you so much, Abubakar. So I'm going to pass your question to one of the panelists. Dr. Sam? I see you.
Actually, I will just type in the response.
Okay.
If you go back, there are legislation, the National Health Act of 2014, which is being reviewed or revised. It's the one point, and it has a lot of challenges in terms of where it describes roles and responsibilities, and particularly allocating resource, national health insurance 50%, national primary healthcare development agency 45%, and then 5% for emergency health management. Again, that is, to me, and people said, oh, it took 10 years for it to get approved, but that's a need to rework that document. 2, there's a health policy which clearly states primary healthcare as a corner strategy. It's just like tick the box, it's there. Nobody, like Chima said, oh, everybody defines primary healthcare the way they want to define it. And like you say, you can adapt it to your context, but not redefine and reinvent it anyway. The third one is if you look at, there's a primary healthcare strategy and guideline. To what extent states adapt is a problem. Then lastly, there's the primary healthcare provision fund, document and guidelines. Again, the way the states and court interpret it and apply it is a case in point. And now the federal government just launched they call it voluntary something fund, voluntary something, and like a vulnerability something group fund or something. Where does that fit in with this 1% consolidated fund and the guidelines in terms of primary healthcare provision? So there's need to be a coordinated approach. Primary healthcare development agency cannot act as if it's the Ministry of Health. And the Ministry of Health cannot just say, well, there are agencies and NCDC and they can act on their own. And that's what I'm saying, is strong leadership that brings everybody on the same table and allows functional rules, just like one hand, 5 fingers. The fingers but they don't act on their own. They act in concert with the others. And that's the way we need to really and truly make Nigeria great. Anyway, thank you very much. Over.
Thank you so much, Dr. Sam. I'm going to take one question. Okay, no, Rukayat, I actually see your hand is raised and you also have a question on the group. So please let us know if you have a question or comment and then go ahead. You can go ahead to unmute yourself.
Hi, good morning, everyone. Thank you for this brilliant, I'll call it a workshop that you've put together. I have learned so much. It's a comment, I've listed quite a few questions, but in the interest of time, I think I'll just make a comment and ask one question. So I'm in the diaspora. I'm listening to Dr. Sam speak, and he quoted, I think one of the policies in 91, and I was like, oh my gosh, I was 1 year old. So there's quite a lot of us in the diaspora, that a lot of public health specialists that want to actively get involved in sort of supporting, strengthening primary healthcare systems within Nigeria, but we really don't know where to start. Because when you look online, we are so used to, well, for us that grew up here and, our education, everything was based here, we're so used to just referring to policy documents and, typing whatever you need to search for online, and you have all the information you need. But trying to navigate that in the Nigerian setting is a nightmare, to be honest, to be very frank. So there's quite a few of us that are very passionate and interested in strengthening. We are aware of the challenges. We all see it. We have families back there. We come back home often. But what avenue is there for us to sort of get involved and influence and support the strengthening, apart from working with NGOs? I have an NGO that I've set up, but it's not set up in a way that it would influence policy. It's almost like a reactive setup because, for instance, I came home a few years ago and I was shattered because I saw so much poverty. I saw so much issues around determinants of health and well-being that needs to be addressed that were not being, addressed really. So we're not trying to push the blame here. We just want to know, how can we help? How can we support? How can we use our experience and knowledge to give back to help build a system that's suitable for all? I think that's it for me. Thank you.
Thank you so much, Rukayat. I think I'm going to hand over to Professor Chima to respond to you.
Okay, thank you for that question. So I'll say something and then connect it to just a comment on an earlier question. One, I think that it's not. It's always said that people should come and help. People in diaspora should come and help. There's a lot of talk about that. The reality is that when you come down, you meet a lot of bottlenecks, except you now find yourself to, supporting at the NGO level. And I say this carefully, okay, also recognizing that we have people from states here and also those leading even like state agencies for primary health care. One of, what leaders do really is to create platforms through which they can harvest as many resources as possible to achieve collective objectives, collective goals. And I think that especially that's what, especially at the state level, that we can turn our agencies into platforms that are channels that as many people as possible can come there and find that you actually have an objective and you have room for them to contribute to doing something to change the face of the state, and especially primary healthcare. And I think that's where that lies, to a large extent, because I think primary healthcare won't shift positively until states take a lot until things are done at the state level, to create the platforms through which all these things are supported. So that's where I'll throw the challenge, and I'll also call that a recommendation for this meeting. Then we can really have a massive, that's like 37 platforms that people in the diaspora, people everywhere, people that even want to play a part, in supporting can play. That's 37 platforms, for heaven's sake. That's significant, if I'll say that. And the other point I wanted to make is that, when we talk about accountability, which is important, seriously here, I think the assumption is that civil society people can actually say things, partners can really hold government accountable, ask questions. No. I've seen that when partners, when you push to some extent, there'll be another partner, another technical group that will be willing to do that thing that one partner is saying, no, for ethical reasons, I'm not going to do. There'll be somebody that will show up with some fund, and they will now warm their ways to the heart of, whatever organization that we talk about that is government. An example that I want to share, because even Ibrahim raised something about, look at what happens abroad, they can't walk like this. That thing that is in the policy is also in the MDCN documents in Nigeria, that if you're working for the government, you shouldn't do this, you shouldn't run a hospital. It's there, but everybody does it. The problem is not that everybody does it. The issue is that if we know that because there's a lot of dependence on the private sector, that this legislation doesn't work, let's adjust it and come up with something that works for our system so that the incentives are clear. If you're working here and you own, look at the implications for you, because we know that we end up depending on those we change it rather than just managing it, and, and all of that. And in the UK, I was at the London School of Economics one fateful day. And that's what I'll close with. I was at the London School of Economics, and I saw the hospitals, big hospitals in London. That is where they go, that is where they were that year to present their scorecard. You present your scorecard to Nigerians. Is it board of an agency? They're not going to say anything as long as they are being oiled. You throw it in the open. Then me, an individual, will wake up and I'll just get money, my personal money, and be shouting that, oh, this organization is not doing well, this agency is not doing well. It doesn't work. I put my life at risk. We have universities. What do we even do with them? That's where the state primary health agency should go there and present the annual report of its activities to people that they are not paying, to people that there's nothing that is tying them, they can't sack them. People that can ask them questions. Why is this figure like this? And we have universities everywhere. Those are the kinds of innovations that will work for our system. Not, oh, the report is out, we keep it. Oh, the board says something. The board won't talk. Oh, I should wake up where I am and start criticizing somebody as an individual. How will I do that? Somebody should come up with a system where these agencies, these organizations, if you're in a state, there's a university there, whether it's federal or state, Go there every year after your report is ready. There are people who are going to ask you questions. Let's have such platforms. And then if there are development partners that want to talk, let them also go during those presentations. If there are technical partners, so that it can be in a place where people can ask the right questions. Citizens can ask questions when they don't understand it. Educational level is still low. What are they going to ask? What do they know that they are going to demand? You know, and when they demand, they need food at the end of the day when they get back home. You demand and then the person brings rice for you. What are you going to do? You know, we need to be practical and work with what exists in our context, optimize them, take advantage of it, and then, you know, we can start making real progress. Over.
Uju, you're muted. You're muted, Uju.
Once again, apologies for that. So, so I see, thank you so much, Professor Chima, for your response. Next up, we have, I see Saeed Gaya. Saeed, I see you have a couple of questions. Please, could you condense it to one question and then ask it to, go ahead and ask.
Thank you so much, Uju, for the platform and all the panelists. It's been very insightful. But I just want to make a comment, a remark, and then of course, it's somewhat also a question. But first of all, it's always just to know that, I mean, writing on what Professor Chima has said about low educational levels and what the people are even supposed to know. There is no state, there is no country in the world that has achieved universal health coverage without the support of the state. Now, the elections are around the corner. And I think we must constantly make this agenda of health a priority. I mean, people are talking about security, people are talking about the economy and all that. The issue of health has to come out on the agenda and I think we are concentrating so much on what the federal government is supposed to do and all those policies and all that, but the state executives are the ones that are not even interested. I worked in Kebbi, for example. I worked in Borno State, in Kano. I mean, and you just see how I mean, the very low level of interest these executives have. Okay, so I mean, I think somebody really has to push these people. If the politicians are not interested, or the politicians do not see this as an agenda or as an emergency, we're not going to go anywhere. In the next 4 years, we're going to be back to this place talking about the same thing, and we keep talking about the same thing over and over again. So I think, for me, I want to know how can we, I mean, I think Professor Chima has talked about platforms at community levels where we can bring stakeholders together, and then people can, for example, present scorecards and people can ask questions. People are supposed to know, what did they actually deserve? How do we hold politicians accountable? Now, I mean, you look at in the House of Reps, more than half of them are not going to come back. These are the kind of things we want to be hearing. For example, you have not, I mean, when in terms of healthcare, in primary healthcare at local government level, these things have to become a priority. It has to be top on the agenda. People have to talk about it, have to harass the politicians. I mean, but I think that's my opinion. Yeah.
Yes, do you have a question? Thank you so much for that comment. Is there a question?
Yeah, I mean, it's just, I mean, the question is just how can we create those kind of fora or platforms such that people are able to, I mean, ask more questions or increase the momentum towards you know, primary healthcare conversations, especially as elections approach.
All right, thank you so much. I think I'm going to pass that question to Dr. Sam. I see your hand is raised. Please go ahead, Dr. Sam.
Okay. I was just kind of typing on, but I was just going to say, let's listen. Again, to just support what you might say, we need to look at, we're alumni of some institutions or the other. So you use your alumni fora. That's the first step. And be advocates and champions for issues and causes that within your community. Second point, there are professional associations. They have been quiet, whether it's NMA, National Association of Nurses and Midwives, what do you call them, pharmacists and all the rest of them. They're not acting as duty bearers. Then the third part is the community of practice. We have experts, we were looking, how do we translate research and knowledge into action? So we need to look at all that aspect. Then we have the NGOs, whether you call it North-South collaboration, diaspora with locals, or NGO within NGO, we cannot form that kind of consortium or whatever. And then the managerial processes are there, but they are not functional. So how do we give them life? And then make sure that at the ward level, because I don't know how many wards there are, but if you're saying PSC, one PSC per word, support one word, adopt one word and give your expertise. And then lastly, but not the least, is the private sector. The private sector has two elements. It has the corporate social responsibility and it has the commercial social responsibility. So that if you look at researches, a lot of things have been done all over, whether ND preventing maternal newborn death, have been sponsored and supported. So we can then scale up innovations. And in my view, this is the beginning to say it's not only a public sector government run business, it's our business. Thank you very much. Sorry, over.
Thank you so much, Dr. Sam. I'm going to take one question from the Q&A chat box. We have a question from Rukayat again. What data sources do we have available that can support us to understand the state of health of the country? Do we really know the exact health needs of our population? How can we begin to use data to understand where we are? Dr. Emmanuel, I'm going to pass this question over to you.
Well, yeah, so we do have the National Health Management Information System, and a lot of service-related data are currently being captured through the National Health Management Information System and the DHIS2. Yes, and the final repository is in the Federal Ministry of Health, but you have decentralized access to this data. So I think it has its challenges, but it's a reliable, curated data that you can go to find out what services are being offered where and what people are accessing the service. So I would suggest that's a good way to start. But of course, there are other program-related data that you can access. Interventions that have been done, for example, immunization services that have been carried out. There are reports on a lot of these malaria programs. And sometimes we found out that, for example, immunization programming, when we do a campaign, the coverage, for example, what we get in terms of numbers covered may be at variance with the actual estimated population of that catchment. So in planning for another round, we tend to rely on that past coverage. So these are data you can triangulate and look at the best way to come around what you are actually looking out for. Of course, the policy documents that have been mentioned are also important. And then agencies that are saddled with specific responsibility also have their in-house data. So you probably need to request. Unfortunately, some of this data may not be publicly available, but they can be approached, like the National Planning Commission, the National Population Commission, the National Health Insurance Agency Authority now. At least NHIS, previously NHIS should be able to tell us what coverage, what are the different categories of people that have been covered in terms of health insurance and the type. So these are places that you can access reliable data.
Thank you so much, Dr. Emmanuel. I have another, before I let you go, sorry, I have another question. During your summaries, you mentioned technology deployment as one of the key areas that we should really focus on if we intend to change how primary healthcare the current primary healthcare situation in Nigeria. And I have a question here from Augustine Adeoshun, who says, what can we do as an individual to effectively integrate technology into the primary healthcare sector, or can technology truly play a role in revitalizing this sector? Seeing as you talked about that, if you have any thoughts around this, I'd be happy to hear them. And we can also, for Professor Chima and Dr. Sam, please feel free to step in as well for this question.
So clearly, yes, we already live in a technology-driven world. We're having this conversation now because of technology. So there are other similar technology or even less cumbersome technology that can be deployed at scale. Some of them have been demonstrated already that they work. M-Health, even things that have to do with just simple text messages, where health workers in remote areas can be supported by text message conversations where they text to find them. There are also call-in applications where they can get to be supported on what's the best step to take in a challenging situation. In the course of COVID, and we've had to rely a lot on in my practice, I had to rely a lot on conversations with my staff by WhatsApp message. Of course, not everybody is on WhatsApp, but I was able to reach majority of my staff by WhatsApp, and those I can't reach, find other ways by call or by text. So it solves a lot of problems. The e-health also is a way that we can use for like electronic medical records that can pick up data from different health facilities and harmonize. So these are options. They are endless, but they need to be deployed to support the gaps and help to advance the course of achieving our goals.
Thank you so much, Dr. Emmanuel. Any responses from Dr. Sam and Professor Chima?
Yes.
I'll say
If I may just ask. All right, okay. Go ahead, Chima. Go ahead, Chima.
I think.
Okay, let me just come in there.
Yes, please go
Okay.
ahead.
I was just going to add that, yeah, in the area of innovations, what the challenge we have is adoption and scale up. And I look at it, and I can give you a clear example or examples. We have chlorhexidine, which we found effectiveness more than 35% reduction in newborn mortality. But has this been scaled up? It's part of the 13 essential drug package. It's not been scaled up. The baby kangaroo method is something that's used for small babies. How well is it being applied and scaled up? If you go beyond that, you look at making babies breathe. We have all these tools of suction, at birth and all that. We have making pregnancy safer. We have delivery kits, which are simple, less than $2 per woman per year. Nobody is really scaling those kind of things up and then we now talk about technology of drones, of dropping drugs and things. And I think we have the opportunity. Nigeria, one, we have the population. Two, we have a challenging context, and therefore we can be very innovative. And because let me say this for the record: if you go to any village, whether Damaturu or anywhere in Nigeria, you will get a cold Coca-Cola, a cold beer. Yet you cannot get vaccine in those places. Then you tell me, oh, it's a logistic problem. I don't think so. It's the mindset. We've got to change. Thank you. Over.
Thank you, Dr. Sam.
Okay, and just to add that, it would be great that we also think of technology. I know the last few years there were things that were dealt with, like taking advantage of technology for immunization, SMS, reporting what has happened, to allow timely use of data to drive change. Now, that person in the primary health care center in my village, in your village, needs information that they can use to solve problems within today and tomorrow. That's the kind of, even if it's for simple things, by the time we get the technology that helps them solve these problems, it will become easier to solve bigger problems over time. I think it's best for us to think about that. And then for that technology to work, ultimately, so the first technology I would say is getting people that can handle technology things at the primary healthcare center. The idea was, okay, there was some recently, okay, empower. We couldn't empower people down. Nigeria was unable to empower people down in the primary health centers. Somebody needs to support the 50-year-old midwife to handle that bit, who does not necessarily have to be a health worker, who has some other skill and can handle this, whether on short-term or long-term basis. That's the pivot of the solution. Then that's the first technology, I think. And then every other thing that we see as technology will have a chance to survive. Thank you very much.
Thank you, Professor Chima. I have, I see a couple of more raised hands from participants. Francis, please go ahead and ask your question or make your comment.
Oh, thank you very much for the opportunity to speak. I must commend the panelists and the organizers and all participants who have provided a lot of insightful discussions on the chat. And I find this a very timely discussion, because primary healthcare clearly is something that if Nigeria gets right, then our health system will be on track to UHC. So for me, looking at the discussions that have gone so far, my question relates to the issue of accountability. I know it's a very difficult one, looking at accountability, particularly from the point of human resources for health, and also from the point of financial accountability. Like, we know a lot of resources have been spent, the NPHCDA, BHCPF, a lot of money goes down into the primary healthcare system. But at the end of the day, who is asking the questions on what really has this money been able to achieve? And then where do we start from? Same approach is going with human resources for health. From my experience, a lot of people want to work with the government, regardless of the level of care, because they feel there's no accountability. I can come to work when I want to. I would like to hear the opinion of Dr. Emmanuel Obetu about how we're able to get healthcare workers to actually turn up on time, be at their duty post, and do what needs to be done, because that is also another problem. So for me, the question to the panelists would be looking at accountability on the end of finances and human resources. Where do we start from? Do we look at it from a bottom-up approach or from a top-down approach? Because it's a problem at all levels, where whether it's at the level of the FMOH or NPHCDA, you have monies being spent, and sometimes you're not able to really see on the ground. It's not about getting audited reports that account for what money did, but we, just like Prof. Chima had said, we seen that, okay, we are seeing tangible results. And if we are not seeing tangible results, we come back to the table and said, we just blew $10 million and there's really nothing to show. We have a report from WHO or one of the partners saying there's marginal improvements in maternal mortality. That's not enough to account for $10 million. So where do we start from in fixing these problems, especially around financing and human resources for health? I'll stop there because I know we're short of time. Thank you very much.
Thank you so much, Francis. Please go ahead.
Francis, you called me out. You called me out on a very difficult challenge.
Yeah, I did.
Yeah, so what are we doing? How are we able to solve the problem? So for human resource for health, it's quite challenging because I can tell you, I find it difficult to sanction erring personnel. Things as simple as transfers are so difficult to do. And this is being practical, that you need to transfer somebody from one primary healthcare facility to another. You begin to have community and political interference. So I really do not have the answers, to be honest. These were some of the challenges that the primary healthcare under one roof assumedly was supposed to solve. But of course, even the primary care under one roof is not working as smoothly as we expected. So probably if it works the way it ought to work, it may help solve the issue of sanctions for human resource health. But again, it goes back to the issue of money too. There are a lot of compromises along the ladder. So I think, in my opinion, even CSOs are some of the best options to provide accountability in terms of the CSOs should be able to help us name and shame. They should be able to be whistleblowers, because within the system, it's difficult for the system to sanction itself. Because at some point, persons who are responsible for sanctioning compromise at some point. They are either linked, maybe there's some nepotism involved or some other inclinations, or the community people go and beg, and that, you know, you shouldn't be the one that is disturbing our brother. Especially, it's even worse if maybe you are ethnically linked to the person you are trying to sanction, and it becomes a village issue. So that's why I think CSOs will be a very good way to help navigate this accountability issue. They should call government out. They should call us out when we err. They should shame us, and they should also name when people do well. I think that would be a good way. And I think Dr. Sam mentioned the use of a scorecard. That's one way, because the scorecard also has a thematic area that has to do with finance, that has to do with human rights. So these are options that I think, but to be driven mainly by CSOs. Again, sincerity of CSOs, because CSOs also need to be accountable, because sometimes CSOs drive some of the mishaps and nobody sanctions them.
Thank you so much, Dr. Emmanuel. I see Dr. Sam has given us some comments, has given us some response in the chat. So Dr. Sam, just give you the opportunity to say it out loud.
All right. Okay, I was just suggesting that, yes, the accountability starts from the provider and also the recipient. And we need to look at it as a kind of a mutually, a related approach. But first of all, we have at the ward level, which is the minimum level for where healthcare should be managed. If at that level, the managerial processes, which means the committee that manages health leave within the ward, must be held accountable, because there's a guidance and there are frameworks and there are indicators and there are results that they're supposed to achieve. The second part is we need to look at also at the national level, we have actors like budget who do continue to challenge government and say, okay, not only just budget tracking or looking at allocation, but looking at expenditure, what we call public expenditure tracking analysis. Where is the money going and what's it being spent on? This is what we need to, because this is part of the transparency initiative. The third bit is that we have, as donors, we've worked with states to have what we call a mutual accountability framework. So we agree on a set of indicators and then we hold them to account and then we meet quarterly and do but it goes beyond donors doing that. That's why I think I like what Emmanuel is suggesting. CSOs should take up that kind of responsibility. And I think whether we like it or not, the CSOs should be strengthened in terms of understanding what the program is, what is expected to deliver, and how to measure it, because not everybody understands that, that exercise. So that it's just no matter, these people have reached 15%. Who says 15% is the minimum that should be invested in health? I don't know, because World Bank just suggested that. That is BS. So let us be very frank. What is important is the government, local government, state government, federal government, making enough investment to make that people healthy and stay healthy. Over. Thank you.
Thank you so much, Dr. Sam. We have two more questions. We have one from Maria Saleh. She says, thanks for the rich conversations. Fundamentally, the funding in the health sector is key. What options are there for states to meet WHO recommended budgetary allocations for primary health care? I'm going to hand this over to you, Professor Chima. Shall I repeat the question?
The health states. I mean, there are states that are doing things. And thankfully, Ibrahim started from Lagos and is all connected to things. I mean, at the event that happened in Washington last week, there were talks about how different groups can have additional funds, even like taxing some of the difficult things to be taxed, cigarette, alcohol, etc. And I know a lot of people will jump into, and they showed really that there's a lot that you can generate from that. But then Lagos is generating funds, but then maybe people don't give. Last decade, early in the decade, one of the reasons that people raised why they were not contributing towards a national health insurance scheme was that it was all going to Abuja, and they don't know who is going to hold those in Abuja accountable. That they lost money, they couldn't ask people questions when they sent money related to the National Housing Fund, for the National Housing Fund. There's nobody, they don't know, they are not seeing their money. And that was a strong justification for developing state health insurance schemes. It was strong enough. I know this building, this is where they are. We can go there and ask about our money. And I think Lagos, I don't think that Lagos people are, the leadership there, they are saints. But people are going to ask you questions in Lagos. If you are the governor, if you're in the, people are going to ask you questions because the literacy level is so high. And whether the government is there or not, people are going to eat. At least there are lots of people that can eat without the government and can ask questions. When you haven't reached that, you need to find a mechanism for that. And that's why So there are things that we can learn even from Lagos about how people made money and other states. But I will emphasize a point that I don't think Nigerians are terrible. I think Nigerians follow when they see that they can trust something or somebody or a place. And that's what we need to find a way to create. That's linked to that issue of that accountability. Can we be trusted? And that's something that really I'll leave with us. Can we be trusted? Can we create what will make people trust us as a people that are part of the system? Can we find the ways? I know colleagues have talked about all the other options, and I was tilting to one direction. I mean, I've seen CSOs try to do some things. I've seen development partners try to do some things. We had IHP Plus results. I was a researcher then. I've seen that when it really comes out to asking questions, people are going to step back. There's a reason why I say if I'm going to prioritize who you call CSO, who you call, do we see the universities as part of civil society? People that are already being paid. But if we say, let's find a framework, somebody will get some money from somewhere, maybe a development agency, and create another system. Why not provide what will be used on that day for the meeting to happen? When you draw all those who should provide the results, the evidence, to come there and sit down. And you have these people that are learned as well, because the population educational literacy level is not high enough. You have them sit down and ask questions. Why not? But you see many agencies will just dismiss people in the universities so casually. It's painful when you hear that and you see that how we misuse the knowledge production and knowledge and critical analysis platforms we have in the country and make them so pauperized and not make use of what we have and create systems in the air. Systems, nobody is going to have those CSOs. Nobody writes them in the policy that they can be a place. Look, you are mandated to go here to provide your annual scorecard. You can't write that in a government document, but you can for an institution that is also independent or strong enough. All the others are useful. They have the roles they play. They can play, but we need to take more advantage of what we have. Thank you very much.
Thank you so much, Professor Chima. And on this note, I'm going to invite the panel. Oh, we have a response from Dr. Sam as well, who says funding is not the issue for Nigeria. The absorptive capacity, which I think says less than 60%, is the main issue. This means building the managerial skills and accountability system within the country. That should be more of the focus related to budgetary resource allocation. So I'm going to invite the panelists to please take 2 minutes each, actually a minute each, and just give us your closing remarks. Thank you so much. First, before you do that, I just want to say thank you again for joining us for this very engaging sessions, for your contributions. It's been very interesting. I really learned a lot personally, and it's been an honor to moderate the session with you. So please, in 1 minute, just give up your wrap up, your closing remarks. I'll start by inviting Dr. Emmanuel.
Yes, thank you, Ju. I think I've actually also enjoyed myself, and I'm privileged to have been co-panelists with Dr. Sam and Dr. Chima, who are very much senior colleagues that have been privileged to also meet outside of Zoom. So I've used 30 seconds of my 1 minute, but I think I just need to give this. So my passing shot is that there should be health in everything and everything in health. Meaning that in all we do, everything we plan, we should ensure health is part of it. If you are constructing a road, ask what is the health benefit of that road? How many primary healthcare facilities will benefit from that road? If you are going to put a health facility anywhere, we should be asking, how does it integrate to other systems? Where is the primary school located? How are the children going to benefit from that primary healthcare facility? The water supply in that primary healthcare facility, is there one? So there should be health in everything and everything in health. That's my passing shot.
Thank you so much, Dr. Emmanuel. Thank you for your time today. Next up, we have Dr. Sam.
Right. Again, thank you very much, Juju, and others. I typed it in and I said, health finally should be seen as a business with high return on investment. Particularly, I have an acronym, ABCDE. We need to continue to advocate. We can't stop. Just like continue to preach to those politicians. We need to build a system, whether the primary healthcare foundation or the health system. Then we need to continue to challenge the stakeholders and hold them to account. If we don't do that, then we've lost it. Then finally, we must educate our mothers and we must support our children through early care child education. This is where we can and we will be able to change those indicators. And again, great pleasure to be with you all. Have a wonderful week and God bless.
Thank you immensely, Dr. Sam. Over to you, Professor Chima.
So while many things are important, the health infrastructure is important, but we have lessons to learn from rivers that built infrastructure and people were still not going in many communities. Finance is important. We need to learn lessons in places where they have thrown in a lot of funds and then things still didn't work. We have places where there have been community things, Kano, otherwise. There are lessons from Lagos where they pulled PHC facilities together and engaged the private sector in being managers and they held them accountable. We can step back and think about primary health care and the system and how we can succeed by thinking about our friend, our colleague Emmanuel, that is the director of PHC first. What can we do to make Emmanuel, that is heading PHC in a local government area, to succeed? That's where our conversations should begin. What do we do to make him succeed in that local government area? If we can answer those questions, support him with everything he needs, hold him accountable for results, then one LG at a time, primary healthcare picture in Nigeria will change. Thank you.
Thank you so much, Professor Chima. And thank you to everyone who's attended this session. We really appreciate your time and your engagement and your fascinating questions. And my sincere apologies if we're not able to respond to your question. Please feel free. Chidima shared that there was an email shared earlier. Please feel free to send any questions that you feel we did not get to that email address, and we'll do our best to get one of the panelists to respond to it and share it back with you. Apologies once again, and thank you for your time. So finally, I'm going to hand over to the next year host for the closing remarks. Thank you, everyone.
Thank you very much, Doctor. On behalf of the partners at Next Year, I would like to thank everyone for attending this dialogue on revitalizing Nigeria's primary healthcare system. I would like to particularly appreciate Dr. Ujones for a fantastic job, and all our panelists from Professor Chima to Dr. Sam Abo and Dr. Emmanuel Ekwetu for all your insightful contributions to this important discussion. Finally, to the over 65 attendees who graced us with your presence and time, Next Year Health is most grateful. This dialogue is part of our activities at Next Year to create the society we want to live in. At Next Year, we are passionate about solving the complex development challenges facing Nigeria and Sub-Saharan Africa in general. We achieve this through our different business units, such as Next Year Advisory, Next Year Power, Next Year Security, Peace and Development, and Next Year Health. Thank you once more for joining us, and please expect more similar events and discussions going forward. Have a great day. Thank you.